Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend Colin Hung. The world of technology and healthcare are ever changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news meshed together in new ways, which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we're going to be discussing if Epic is the biggest obstacle to interoperability in healthcare. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 18 years of health IT blog content at healthcareittoday.com. When did you last have a problem with interoperability in healthcare, Colin? Mine was like 3 weeks ago. I was trying to get these x-rays, MRIs actually, officially. And I had to go in 4 different times. I got 10 different DVDs, and I still not sure if I have everything.
Mine wasn't quite as recent, but it was a few months ago. I was trying to get medical records for one of my kids, and it's just got the runaround, go to this department, go to that department, and then had to pay to get the record because it's an older one. And anyway, it not fun, but unfortunately in Canada it's sort of expected. We're
That's
not very
interesting.
interoperable.
I mean, we'll have to pull in the international perspective. On the bright side, my wife actually was having some stuff done, and she'd had a test done a year before. She was having it again, and she was able to pull up her record from a year ago to see the size of it to compare to the current one. And so, it actually worked for her. So, there is some progress.
So, John, I mean, very interesting, controversial, interesting topic for this episode. Uh, do you think? I mean, first of all, I think maybe give the folks who are listening and watching, give the background of what this title of and how this topic came about.
Yeah, so the topic really came out of a Business Insider article where, to be frank, they blasted Oracle, Oracle Health, I should say, Oracle Health, and they appropriately said it was a bit of clickbait, right? The headline was clickbait. It wasn't the best journalism you can see, and in fact, most journalists would probably say, "Is that journalism?" But there are some challenges, right? So it turns out, I think Oracle Health would claim Business Insider took, a bunch of little negative stories that have happened, put them into one story with a clickbait headline and published it again, right? And so, it was mostly stuff we knew about, and it was taken in different, it lacked context and all sorts of things, right? So, but from that, Oracle issued this terse reply, which maybe we need a little Sway Health moment to say, should a vendor reply like this? But anyways, Oracle Health did, and they published on their blog, how irresponsible the reporting was, and it was clickbaity. But then within that article, they said that, and they said this, that, and I should read the exact one, but they said, everyone in the industry knows that Epic is the biggest obstacle to interoperability in healthcare. And anytime someone says everyone, I always take it with a little grain of salt. Yeah, you're overstating it, right? Everyone is not, right? Like, certainly Epic people aren't. But, and so that's where it came from. Is they kind of asserted in this announcement, if you will, this blog post, that Epic is the biggest obstacle to interoperability in healthcare. So that is the starter question. What do you think, Colin? Is Epic the biggest obstacle?
That's a loaded question, but for me, very simple answer, no. They are not the biggest obstacle to interoperability in healthcare. I mean, and the reason why I say that is just simply there is no incentive and no momentum behind interoperability anyway. Like the problem is not a vendor, a technology. The problem is who's paying for it and how is it supposed to get done? Right? Like in the sense of semantic interoperability, it to me is the biggest challenge, and the willingness to actually share data is the big challenge. Yes, there are many players in the ecosystem and don't want to share and are reluctant to share, but it's not just restricted to me, in my mind, to Epic. So I just think there's just nobody wants to pay for it, and there hasn't been really compelling business cases. Some are emerging now, but hey, like we're here because there was no incentive to be anywhere else.
Yeah. I mean, I go back to the beginning, which is essentially what you're saying, which is the clients of Epic and Cerner or Oracle Health, whatever you want to call it, and every EHR vendor didn't want interoperability, right? Like, and so, they gave their users what they wanted. And so, in that regard, I think there wasn't the incentive for the customer to say, hey, EHR vendor, I want you to do this. And to be fair, I think I've said this on a previous episode. I think Judy took the slings and arrows of not being interoperable for her customers who didn't want it. And so, but that's where, I mean, it might be the wrong question. Is Epic the biggest obstacle? Because, there's different ways to look at it. First is like, is Epic blocking interoperability? In some ways they are, because if you look at it, you say, could Epic do more to support interoperability? And I think universally the answer is yes, they could do more, right? But are they doing something? And many would argue, like I'm channeling my inner Brendan Keeler right now, who used to work at Epic, so there's a little bias there, but take it for what it's worth. He's like 4 companies since then. But he would say they're the most interoperable of all the HR vendors and the most open with the best documentation. And I've heard that from a lot of vendors that they really do have a good structure to be able to integrate with you. I think the problem is they pick and choose their favorites of who they want to interoperate with, who they want to allow their APIs to go through. I think Judy really has instilled this, who do we trust with the data that's in Epic and the data of our clients? She takes that really seriously. So, she is in some ways being an obstacle because she could do more than she is. But is she the biggest? No, I'm with you. I think it's the incentive structure that is the biggest problem. And these vendors are just reflecting that incentive structure.
Yeah, and to me, you swap the company Epic with any other EHR company, and you could argue they're all following in that same boat. Could any of the EHR companies be doing more for interoperability answers? Yes, right. But I think as we're talking about here, I don't blame them that we're here, right? Like it's not their fault. They just didn't get the push from their customers until now, because of info blocking rules and things like that, to actually put a lot more effort into it, right? Like, if interoperability was such a hot button issue, it would have been solved by now, right? Because there would have been demand from people, there would have been demand from a lot of parties to fix this. But right now, it's just more of, I think it's a nice concept. And hey, don't get me wrong, there's definitely a business case and it definitely affects patients. But at the end of the day, it wasn't something that was as important as some of these other features that got baked into EHR. So we are where we are because of the incentive structure. Now we've got some penalties because of some of the things and some of the things happening now with QHINs and Kefka. We're getting some movement, but it's taken this long because it took that long to put the structures in place.
See, and I think those things are just going to obfuscate the need for interoperability, because that's what most EHR vendors, including Epic, have done. Hey, we've done up to the standard. Like we've done up to the QHIN, we've done up to the, care quality, we've done whatever other standard, direct, etc. Right? Like we've done all those standards. And that's actually what annoys me most about this. And in this part, it actually applies equally to Oracle Health as it does, Epic, right? And pretty much most EHR vendors. Probably Athena Health is the most open as far as the APIs, in my view. But you look at that and you're like, if Epic would have just said, here's our API, here's how you can get access to all the data, and sure, here's how you have to, provision yourself and everything like that, then we would have interoperability. They could choose to just create the standard and we would have that available and everyone else would have to follow along, I think, so and to me that's where, sure, did they have the financial incentives? No. Were they battling out with other competitors to try to survive, and did they want to put their resources into interoperability, which wasn't asked for by their customers? Absolutely not, right? They didn't want to invest in that because they were in a battle for market share. But it's the right thing for the patients, and that's what annoys me.
So John, in your mind, what are the other obstacles then to interoperability? We've already talked about the incentive structure, but are there other obstacles that you're seeing to interop in healthcare?
Yeah, I mean the incentives lead everything, and we have the wrong incentives now. And we're seeing some change, value-based care we can throw out there. Like you said, information blocking, like CMS, ONC, they're using everything they can to change those incentive structures. But yeah, it's the wrong incentives. The other one that is a challenge, I think, is the standards. Now, if you don't have the incentives, you don't spend the time to create the standards. And everyone else is like, well, banking figured it out. I hate when they say that because it's like, well, banking is like so simplistic compared to health data. As my buddy Mario Highland would say, he said health data is an order of magnitude more complex than this banking data. So, sure, can it be done? Yes. If we had the right incentives, could we do it? Yes, we would. And it's being done to on a lot of areas of healthcare, but that's a really, a big problem. I think here's how you know that interoperability is a challenge, even within organizations who may have multiple EHR or multiple systems, they aren't solving it. And it's in their best interest to solve it privately within their organization, and they haven't solved it. So like it's not a simple problem to solve.
No, no, and I think what I'm reminded of when I talk to people who are in the interoperability space and who are at these provider organizations that have multiple systems, they keep reminding me to say, Colin, the goal is not general interoperability. I just need the 10% of that medical record that one department needs. So I don't need to send over the whole record. So to your point, John, like maybe they're not making Athena to interoperate with Cerner, but the answer is I don't need to. I just need the image. I just need the lab result. I don't need the rest of it. I don't need all of the notes and all the history. I think a patient would want that, right? But to operate my business, to operate my organization, I don't need all of that. And I hear this over and over again to say I'm interoperable up to the level I need to be, and I'm sure that is sort of hindering the fully interoperable world that we all would love to be in, right? Uh, back to the point we were making before, there just wasn't a need.
Well, and
Um,
what annoys me is that you just described what they want, and that's what most people want. And we see some implementations of that. There's literally billions of transactions being shared all the time, and it is making an impact for good. But, instead of sending what we need, what are we sending? CCD that's so
CCDAs.
chock full of junk that's barely useful, even if you do filter through it, right? And so like that's the other problem. We're not sending the stuff we need, we're sending stuff we don't need that then has to be filtered out to find this one kernel that actually could be useful in this case, but it's not everything else that we really needed. And so that's the other problem, is like, what should we be sharing? Have we even answered that problem? We do actually in the imaging case. Like that one, we know we're getting duplicate images, but again, that's the wrong incentives. That's the obstacle, is if I actually solve that problem, now I'm not having double revenue, and that's meaningful to some organization.
Yeah, no, and I have to say that as well. I think there's obviously a financial challenge, right? Some of these tools that help organizations to become interoperable are quite expensive. And so the smaller players out there that even though they have maybe the desire, the willingness, there's an affordability challenge. And I'm just sort of blanket the term on here, but I think that's a challenge for the industry as well as to how do we drive down the cost of interoperability? And because it's not just the technology as well, it's all around cleaning up the data to even make it interoperable, right? Like to your point before, John, like if you've come through 3 or 4 acquisitions, trying to get all that data into one single data lake that you can access yourself, even that's not very well done. And that requires time. It requires a lot of consultation and things like that. And so I think there's an affordability issue as well that is a big obstacle to interoperability.
Yep.
Hey, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and me, Colin Hung. Today we're discussing if Epic is the biggest obstacle to interoperability in healthcare. A salacious title indeed.
We'll do our own
So there you
clickbait.
go. We are our own clickbait. So, John, let me ask you this. What could be changed that actually would help interoperability become more of a reality today?
I was pondering this question, right? Like, what could be done? And the question came to my mind. how do you make someone care?
Mm.
Right? Like, ironically, I actually heard a story, when I was talking with Judy one time at a conference, and I think what made her care was her kids. And I think it was her kids or her husband that came to her with a situation, said, "Why aren't we doing this?" And it woke her up and said, "Yeah, we actually should be doing this." And I think, Care Everywhere was born out of that, as I understand it, as I remember. So, like, I think we need those stories of impact where interoperability didn't happen, or even on the other side. I mean, I remember at a conference I was talking to a doctor and we're dove into interoperability. He said, "Hey, John, it's not perfect, but let me tell you, I was working the ED. I was in the ED. Someone came in and asked for a drug, had all the symptoms he needed, the pain, knew what to say, etc. I would have just issued that drug right away." He said, "But I did a quick search, and then it pulled up that essentially he had a history of seeking this drug and realized that this patient was a drug seeker, and maybe this wasn't the best way to do it." And so, he gave that real life example where he was able to not prescribe that drug and instead, address it in a different way. But if interoperability wasn't there, he would have just prescribed it, and, he didn't know any better. And so, I think those stories may help, but it's like, how do you switch someone to care when there's not the financial incentives?
Yeah, I like what you said there because I was going to say something similar. I think, we in the media have a play here, right? Like to highlight these stories both on the good and the not so good side, and to tie it to interoperability. I think that's really where I look at it and go, I don't think enough stories have been written about the problem being interoperability itself, or how interoperability led to the problem or was a contributor to or towards it. I think we say other things. There's other causes for these issues, right? And I think as people more wake up to the possibilities of what interoperability can do, now we realize, oh, when it doesn't happen, oh, like this, here's the outcome. Patients are suffering needlessly. We're giving away, or we're prescribing things that aren't needed. We're doing double or triple the amount of work getting all these tests done, where if we just had interoperability, we wouldn't have to do this. And I think one of the things, very strangely, that I think is incentivizing this is actually the rising costs. So
Hmm.
as costs rise in healthcare, I think now people are realizing, oh, you know what? Now there's actually like, forgetting about penalties and all that kind of stuff. There's now actual financial incentive for me to go and figure out whether this is already being done and whether this is necessary. Whereas before, things were we just go ahead and just do them, right? But as people become more cost conscious, as things cost the organization more, I think they're going to be, hey, you know what? I need to go see if this has already been done by someone else, and do I really need to do it? I'm hoping that some of those incentives will really come in play. And I think if we stay in this sort of weird economic environment, I think actually it does help interoperability.
Hmm. Yeah, I think you're right on the costs, that are happening, and there are some shifts where, value-based care, or at least some form of that, is going to matter for a lot of organizations in a meaningful way. But I actually look at the problem, and part of the problem for this is that we look at the volume of transactions happening today and we think, wow, we're already sharing billions of records, right? I mean, every one of them can do some sort of millions, billions, whether it's, a health information exchange, or whether it's Epic, or whether whoever it is, right, that you're talking to. Oracle Health can do it, right? Hey, here's how many records we're exchanging every day. And literally billions are changing. But do we understand the magnitude of the problem if we were to solve it properly? Like, if the magnitude of the problem is trillions, well, then billions doesn't sound so big, right? And so, maybe that's the story I would like to tell as media, is I would love to be able to see that, hey, someone's doing trillions of transactions and someone else is only doing billions. Then show that, hey, we're doing it and we're doing it in a big way. That would be a compelling story. And that would actually, similar to when you shame a doctor and the competitive environment of doctors because of med school, the same thing would happen in the industry if they started to see it. The other problem that, I think we should look at, if you talk to any HIE, when they're trying to get government money, they determine what kind of exchange they're going to do by, the interest of the political person who funds them. So if that political person loves pediatrics, then guess what? You're doing data exchange of pediatric records. If they like mental health, you're doing that, right? Et cetera, et cetera. And so, if they got opioids, you're changing medication, right? Like, so I think that's the other problem is it's a little bit too politically driven, especially on if you expand to the HIE side of things and the government funded interoperability.
I like it. I like it. You hit on something that I was going to say, like not a wall of shame, but maybe a wall of tribute, right? The reverse of that. To say, actually, it'd be very cool to do what you said, John, where which organizations out there, and I'm talking about vendors as well as providers, are doing a good job and have a high ratio of sharing, right? So, hey, these guys or this organization does this many encounters in the year, or this many generates this amount of data. And it turns out, actually, they're sharing this much data of it on an annual basis. So what's that delta? Like they're sharing 30%, 40%, 50%. Because that could give an indication of wow, how interoperable and how much effort have they put into it, as opposed to let's say another organization that's less than 5%, right? Like you can at least look at that and go, hey, maybe there's something we can do here to help, right? At least you know where some of the problems are, because right now you can it's hard to know who is not being interoperable and who is, right? We have no clue because to your point, we have no standard of which to judge that,
Yeah.
right? Because everyone says they're interoperable, and the answer is yeah, they all are. They are all capable of it. But like, are you only doing 5%, and this organization over here is doing 80%? Those are very different stories.
Yeah.
And I
And
think
I
that
like the
might help.
percentages. The percentages put it in a different perspective versus I'm doing billions. It's like, okay, that's great, but you should have done 100 billion, right? Like, whereas, hey, I'm doing 100,000, but guess what? I could do 120. Like the percentage would solve for that. As you look forward into the future, 10 years from now, something like that, where will we be with interoperability in healthcare?
The skeptic in me, John, says we'll still be talking about it, right? Because the amount of data and the type of data that we generate in healthcare is constantly growing, right? I mean, how many billions of petabytes or whatever Google, whatever the number is, how much of that kind of stuff do we generate every year in healthcare? And it's just growing, right? As we get more imaging, more tests, more this and more that. I just think we're still going to be talking about interoperability 10 years from now because there'll be some new piece of data that we haven't figured out how to share yet, and there's no standard for. Right? So I think the skeptic in me says we're still going to be talking about it. I think more data, more of the critical data will be shared, so we won't run into the problems where someone's going to, have suffer. I think patient suffering because of interoperability problems will die down in 10 years. I think we'll have figured out most of the critical stuff. But I still think we're going to be dealing with some of these challenges 10 years from now, unfortunately.
I mean, you gave a pretty rosy ending there that I actually like because I think you're right. I think when patients are impacted clinically, we usually solve it, right? If it's going to cost you extra, but we may not. But if it's going to impact you clinically, we work hard to do that. That's why even like the downtimes from these ransomwares have been so damaging is because they're actually hurting patients, and that story resonates in a different way. Yeah, I tried to think how could I create a rosy outlook in 10 years? Could I even imagine a scenario where, it's a largely solved problem, if you will? Certainly there's always going to be more to do. There's going to be edge, people on the edge that aren't doing it, whatever. But I'm like, I just can't imagine even in 10 years that we've solved a large portion of it. Maybe there will be pockets where we're like, okay, medications are solved or something like that, right? Which some might argue is already solved today. But there may be some different areas like imaging. Could imaging make a big thrust, and we finally are able to share images, and we all have 5G, or I mean, I guess by that point, what is that, 12G, whatever? At that point, right? They was like, oh, images is easy to share, and storage costs almost nothing, and it's distributed across all this. Like, so maybe there's some specific areas where you're like, okay, yeah, that's a solved problem. But on the whole, will my data be where it needs to be when it needs to be it to the right person who needs it in a private, secure way? Uh, I don't think so. and the really cynical side of me, which if I'm not this cynical, but I would jokingly say that yeah, all that data will be available to whoever wants it on the dark web. So
Yeah.
if they want it, they can go get it.
Yeah, it won't that be a very terrible story to tell, right? Like the only way we've achieved interoperability is because the dark web has it, and they're the ones who consolidated all the data.
So the new dark web monetization plan is like, you want your full health record, buy it here.
Can you imagine that? Maybe the dark web should apply to become a QHIN, right? Like
The dark web is on the QN network.
oh man, that would yeah, we joke about it, but that's like that what a terrible outcome that would be. But yeah,
They, they,
I
they
guess
won't be
I
able to
guess
solve the problem either, though, right? They don't
no,
need to.
that's exactly. They don't need to, but you're right. I think just given our history, I don't see a lot changing because we know that there's no economics yet that really are driving this. There's clinical reasons, as you put. I think we'll solve some of those things, and I do agree with you. I think we will solve this for imaging and maybe for prescriptions and those things. SureScripts talks about all their interoperability stuff, and most of the countries on that anyways, right? Like so, there's a lot to say there. And as you said, like as the technology and the capacity changes, we might get there very quickly. So I think when you look at it in that specific thing, I think I'm more optimistic. Like, hey, are we going to achieve it for imaging? I think we probably could. We'll probably get much further along. But general interoperability, yeah, we'll still be talking about it.
And we're going to hear from all the imaging interoperability people now. They'll be like, it's just as hard.
That's probably true. And probably 10 years from now, we're still going to be having people blaming Epic for being the biggest obstacle to
That
interoperability.
sounds like a future episode. Will Epic be around in 10 years? What will be their influence?
All right. Hey, well, we're at the end of another episode, and thanks for all of you who tuned in to Healthcare IT Today. You can find more details about our show by checking out the programs page on healthcarenowradio.com. And please share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm Colin Hung, along with my friend and Health IT collaborator, John Lynn. Thanks for listening, and have a great week.